Welcome to Takeda-sponsored educational program Restoring Hemostasis with 4-factor prothrombin complex concentrates in patients receiving anticoagulants. During today's session, you will hear from Peter Tureczek, Oliver Grotke, and Angela Simon. These are the speakers' disclosures. Our presenters will walk us through the transformation of oral anticoagulants landscape and present how 4-factor PCCs are used in the bleed management in patients who require anticoagulation.
A warm welcome from my side to this webinar. My name is Oliver Grotke. I'm a consultant anesthesiologist from the University of Aachen. I have a specialization in coagulation. So I will talk first about transforming of the oral anticoagulant landscape. So thrombosis is a common pathology underlying ischemic heart disease, ischemic stroke, and VTE. And about 1 to 4 deaths worldwide are due to ischemic heart disease and stroke, causing an estimated 30 million deaths each year. So therefore, it's really important that millions of patients worldwide are treated with oral anticoagulants for stroke prophylaxis in patients, especially with AFib. And we see more and more patients getting older, so the demography is changing, which means that in the future, we will see more patients being on an oral anticoagulant. Additionally, the use of oral anticoagulants is suggested by guidelines, of course, for patients with deep vein thrombosis, pulmonary embolism, or any kind of pre-existing cardiopulmonary disease. For about 70 years, being invented in the 50s, the vitamin K anticoagulants were the standard of care anticoagulants for long-term treatment and prevention of arterial and venous thrombotic events. There are definitely different drawbacks of the use of VKA that you're probably all aware of, and especially finding a proper therapeutic INR range for those patients. So in 2008, the DOACs, direct oral anticoagulants, were licensed for the first time on the market. On one side, we have the thrombin inhibitor, dabigatran. On the other hand, we have the factor Xa inhibitors, rivaroxaban, apixaban, and edoxaban, which, due to several reasons, such as ease of use, lower bleeding risk, are now the leading oral anticoagulants pretty much worldwide, and we see more and more people where we have an adoption towards the DOACs. However, of course, any oral anticoagulant does have a risk of bleeding or increases the risk of bleeding. It's lower in the DOACs and VKA. However, depending on the data you look at, you have about 1 to 3% of bleeding rates. And in such situation where you have severe bleeding, reversal with an unspecific hemostatic agent or alternatively with an antidote has to be commonplace to restore hemostasis. And this is especially true in life-threatening bleeding, of course, or in high-risk surgery.
I'm Peter Tureczek from the PDT Global Medical Affairs Department and serving there as a scientific expert. I'm going to introduce you to prothrombin complex concentrates. As you can see on this slide here, there are 2 different kinds of PCCs, so-called 3-factor PCCs and 4-factor PCCs. What's the difference? The essential components in prothrombin complex concentrates, which are plasma-derived products, are vitamin K-dependent procoagulant coagulation factors, factor 2, factor 7, factor 9, and factor 10. While 3-factor PCCs contain primarily prothrombin, factor 2, factor 9, and factor 10, they have a lower amount of factor 7. 4-factor PCCs are characterized by a more balanced composition of these procoagulant vitamin K-dependent proteins, prothrombin, factor 7, factor 9, and factor 10. So they have a higher factor 7 content than the 3-factor PCCs. But as you will see on the next slide, there are more differences between the products, and the composition is even more complex. On this slide here, you see the comparison of fresh frozen plasma on the left with 3 commercially available prothrombin complex concentrates. Prothromplex from Takeda, Periplex from CSL Behring, and Octaplex from Octapharma. If we just focus on the first 4 lines, the procoagulant, factor 2, factor 7, factor 9, and factor 10, you will see that there is an almost balanced composition of these 4 factors, and that is why the 3 products, Prothromplex, Periplex, and Octaplex, are 4-factor PCCs. Fresh frozen plasma, to the contrary, has a much lower content of vitamin K-dependent proteins. The content is, per definition, 1 unit of factor per milliliter, while in the concentrates, the concentration is, of course, higher. It's 20 to 30 times as much. But then the differences come between the 3 commercially available 4-factor PCCs. If you look into the other proteins here, like protein C and protein S, which are also vitamin K-dependent proteins, but they are anticoagulant factors, you will see that the composition here differs between the products. And if you go even further down for other components which have anticoagulant properties like antithrombin and heparin, you will find out that Prothromplex and Periplex have a quite high concentration of antithrombin, which is almost lacking in Octaplex, while the heparin content in Prothromplex is the highest, following the recommendations from the standardization subcommittee of ISTH, which was issued in the early 1990s as a recommendation that 4-factor PCCs should contain heparin to prevent them of being thrombotic under certain instances. There is also a difference between the different products with respect to viral inactivation and elimination procedures, but all these 3 products are safe as far as pathogens are concerned. Now, how these products work, you will see in the video that describes the mode of action of prothrombin complex concentrates.
Under normal circumstances, blood vessel injury causes a response in which platelets adhere to exposed collagen fibers and become activated, initiating a coagulation cascade that results in the formation of a blood clot to prevent further bleeding. The coagulation cascade consists of 3 pathways: extrinsic, intrinsic, and common. In the extrinsic pathway, factor 7 binds to tissue factor receptors on exposed smooth muscle cells and fibroblasts at the site of injury and becomes activated, forming the extrinsic tenase complex. Factor 10 then binds to the extrinsic tenase complex and becomes activated. In the intrinsic pathway, factors 12, 11, and 9 are activated sequentially on the platelet surface. Then activated factor 8 and activated factor 9 come together to activate factor 10 in the intrinsic tenase complex. In the common pathway, activated factor 10 from either the intrinsic or extrinsic pathway and activated factor 5, calcium, and phospholipids form the prothrombinase complex. The prothrombinase complex cleaves factor 2, also known as prothrombin, into its activated form, thrombin. Thrombin converts fibrinogen into fibrin monomers, which are cross-linked together by activated factor 13 to form a fibrin mesh that seals the injured blood vessel to prevent further bleeding. After successful clotting and blood vessel repair, coagulation is downregulated by natural anticoagulants, including protein C and protein S. In patients with deficiencies in vitamin K-dependent clotting factors, the coagulation process is less effective, meaning that clots are less stable and patients can experience problematic bleeding. 4-factor prothrombin complex concentrates, or 4-FPCCs, contain the vitamin K-dependent coagulation factors 2, 7, 9 and 10 in their inactive form. Some 4-FPCCs may also contain the anticoagulants protein C, protein S, antithrombin 3 and heparin. 4-FPCC provides a rapid and effective means of replacing deficient clotting factors to restore the coagulation cascade and prevent problematic bleeding. Anticoagulant therapy may be needed for patients at risk of thrombosis or excessive clotting. Anticoagulants, known as vitamin K antagonists, inhibit vitamin K-dependent clotting factors in the cascade to slow or prevent coagulation. Maintaining appropriate hemostasis is necessary in patients treated with anticoagulants. In the case of life-threatening bleeding or high-risk or emergency surgery, reversal of anticoagulant action may be needed. Treatment with 4-FPCC replenishes coagulation factors 2, 7, 9 and 10, restoring activity of the endogenous coagulation cascade.
So now we will talk about the use of 4-factor PCCs and specific antidotes in the use of bleeding management in patients that do have a severe bleeding under the DOACs. So we do have to categorize the current agents that we do have in the specific antidotes on the one hand side, and on the other side, the non-specific agents. When we talk about the bigatran, the thrombin inhibitor, we do have idarucizumab, which is a specific antidote, a humanized Fab fragment for the reversal of the bigatran. For the factor Xa inhibitors, we do have andexanet alfa. However, currently andexanet alfa is only licensed for the reversal of rivaroxaban or apixaban. On the other hand, we have the non-specific agents, the prothrombin complex concentrate. And I can say pretty much all over Europe we are referring to the 4-factor PCC that's mainly in place, which do contain the coagulation factors 2, 7, 9 and 10. But please do remember, the 4-factor PCCs are not specific. They are the non-specific hemostatic agents that might be used for restoring hemostasis in DOAC-associated bleeding. So let's first look at andexanet alfa. So andexanet alfa binds in a competitive manner the factor Xa inhibitors. It has been licensed in 2019, and it has a fairly short half-life. And we have different studies being shown in phase 1, phase 2 studies in the ANNEXA R and I study that andexanet alfa, giving us a bolus plus a 2-hour infusion, was highly effective on antagonizing rivaroxaban or apixaban. But the main study actually that showed the efficacy of andexanet alfa was the ANNEXA 4 study. The ANNEXA 4 study was a 3B4 trial, a multi-center prospective single-arm open-label study that evaluated the efficacy of andexanet alfa in patients with major bleeding that had the factor Xa inhibitor administration 18 hours prior giving the antidote. However, and this is really important to note, is that only patients were included in the study that had no surgical intervention. And the primary efficacy endpoint was both the change in factor Xa activity and the hemostatic efficacy. Not surprisingly, the majority of patients did have an ICH or GI bleeding. And it was shown that andexanet alfa reduced the anti-10A activity among rivaroxaban and apixaban treated patients by 93%. And the overall hemostatic efficacy rating excellent or good at 12 hours after the infusion of andexanet alfa was 82%. However, when we looked at the safety, there was a note that an overall thromboembolic event rate occurred of about 10.7%, which was about 5% higher than we had from comparable studies, such as the reverse AD study investigating daratumumab for the dabigatran reversal. The overall rate of 30-day mortality was about 14%, which is in the context of severe ICH in a range that we would expect. So now we just recently have the data being published of the ANNEXA-I study. And the ANNEXA-I study was a randomized controlled trial, in the first trial actually in this area, that looked at andexanet alfa versus usual of care in adult patients presenting with acute ICH taking factor Xa inhibitor, especially apixaban and rivaroxaban. Standard of care, over 80% received the 4-factor PCC. The primary endpoint was effective hemostasis, which was a combined endpoint, which was defined as a less than 35 increase in hematoma volume from baseline on repeated CT or MRI scan confirmed, less than 7 points increase in the NIH stroke scale from baseline at 12 hours, and no rescue therapy was used in between 3 to 12 hours post-randomization. And as you can see on this slide, andexanet alfa showed a significant increase in hemostatic efficacy over usual care. So we had about 67% in andexanet alfa versus 53.1% in usual care. However, the point here was that the significance was mainly driven by the fact that we had a less increase in hematoma volume. However, again, safety, here it was confirmed that a rate of 10.3% was shown of thromboembolic events in the andexanet alfa group versus standard of care, which was only 5.6%. And it's currently not quite clear why we do have this higher thromboembolic rate following andexanet alfa. If this might be attributed to an interaction with the TFPI, or maybe of a lack of re-anticoagulation after the event, after reversing. So these are things that has to be investigated further. So when we look at andexanet alfa as a specific antidote, we do have this higher rate of thromboembolic complications, which has been confirmed by the different studies. The other problem that we do have, and this of course especially for me interesting as an anesthesiologist, is that we do not have data out of these studies in the field of urgent surgery or invasive procedure settings. On the other hand, andexanet alfa is also reversing the effects of heparin. So if there's any indication to use heparin 12 to 24 hours after giving andexanet alfa is contraindicated. On the other hand, the efficacy of the reversal effects, which you may be interesting when you have patients that have to undergo surgery and might still bleed, you can't use the anti-10A activity out of your central lab because it will indicate high false values. The other problem are the costs, which are quite considerable, associated with the use of andexanet alfa, and there's limited availability. So what is the alternative to the specific antidote, and what do we do in many hospitals in clinical practice? We can use as an alternative non-specific hemostatic agents, the 4-factor PCCs. And clearly, if we look at the label of the 4-factor PCCs, with a very high grade of evidence, is to use 4-factor PCC in VKA anticoagulated patients that are actively bleeding. And in the field of DOACs, we have to remember that the use of 4-factor PCC is an off-label use. We have 2 big single cohort observational studies that evaluated the hemostatic efficacy and safety of 4-factor PCC for factor Xa inhibitor treated patients with major bleeding. So the one study from Amar Majid published in Blood in 2017 actually confirmed an hemostatic efficacy of 69% in patients that were under either rivaroxaban or apixaban that had severe bleeding defined according to the ISTH criteria. At the same time, when the study was performed by Mamajid, there was a parallel trial by Sam Schulman, which had the same design of the study, also again 4-factor PCC, given to patients that were severely bleeding according to ISTH. And here again, there was an efficacy of 85% following the use of 4-factor PCC. Interestingly, the rate of thromboembolic complications in both studies was significantly lower. If we look now at the dose that was used in both studies, because they used an empirical approach, there was an average of 25 units per kg overall. The advantages of 4-factor PCC is the low cost, the wide availability, but it's not approved for the use in DOAC-associated bleeding. So what do we have in current guidelines? What are our international guidelines telling or recommending us to you in the use of DOAC factor Xa associated bleeding? So the European Rhythm Heart Association published in 2021 clearly, and we can say this actually across all guidelines, is for dabigatran associated bleeding is the use of idarucizumab. For patients with factor Xa inhibitor treatment, for apixaban or rivaroxaban, we have the recommendation to use in life-threatening bleeding andexanet alfa. However, if andexanet alfa not available, then there's a recommendation to use PCC. In the latest European trauma guidelines being published last year, we have the recommendation for patients under rivaroxaban or apixaban with life-threatening bleeding as first line to use andexanet alfa. However, if this is not available, again to use PCC. And of course, the question arises, what's about edoxaban? Here we have the recommendation to use the 4-factor PCC. And the latest guideline on the use, on the treatment of DOAC-associated bleeding, we have the guideline of the ESAIC, which is the European Society of Anesthesiology and Intensive Care, and I was very delighted to chair this group. We, looking at the data, looking at all the data that were currently published, decided that for factor Xa inhibitor associated severe bleeding, to use either andexanet alfa or the 4-factor PCC, because we concluded, after looking at the available evidence, that we couldn't really say any superiority of one over the other agent.
My name is Angela Simon. I sit in Takeda's Plasma-Derived Therapies unit. It's looking specifically at global evidence and outcomes. Today, I'll be going over our ongoing evidence generation initiatives that we believe will greatly improve our knowledge and understanding of 4F-PCCs in the reversal space. Specifically, I will be going over 2 phase 3 trials, one from Octapharma with their LEX 210, one from Takeda with TAC 330-3001, and lastly, I will be going over a real-world evidence study termed TAC 330-5002. In digging a bit deeper into Octapharma's phase 3 randomized double-blind multi-center study, the main objective is to demonstrate the hemostatic effectiveness and safety of Octaplex in patients with acute major bleeding on factor Xa inhibitors. There is a randomization protocol to either low-dose Octaplex or high-dose Octaplex, and the primary endpoint is hemostatic effectiveness, specifically 24 hours after the start of their initial bleed management. There are several safety endpoints of interest, including adverse events, as well as the rate of thromboembolic events. Next, for Takeda's 3001 phase 3 trial, the main objective is to evaluate the effects of TAC 330 compared with other standard of care 4F-PCCs, specifically for the reversal of patients treated with factor Xa inhibitors who require urgent surgery or need an invasive procedure. there is a randomization protocol to either TAC-330 or the standard of care for FPCC. Similarly, the primary endpoint is hemostatic effectiveness, specifically intraoperative hemostatic effectiveness, measured at the end of that urgent surgery or invasive procedure. There are several notable safety endpoints of interest, including treatment emergent AEs, serious AEs, thromboembolic events, as well as deaths within 30 days post-surgery or that invasive procedure. And then lastly, I will be going over the real-world evidence study, shortened to 5002, which is a retrospective chart review study. And the main aim of this is to fill the knowledge gaps that we have about TAC-330 and other 4-FPCCs in the reversal space specific to factor Xa inhibitors. The patients enrolled and their data will be stratified into 2 cohorts, the first being those requiring urgent surgery and the second being those presenting with acute major bleeding. Similar to the previous 2 studies, the primary endpoint is hemostatic effectiveness, and the noteworthy safety endpoints include incidence of thromboembolic events, as well as overall 30-day survival.
Thank you for listening to Takeda-sponsored educational webinar on restoring hemostasis with 4-factor prothrombin complex concentrates in patients receiving anticoagulants.